Hello, and welcome to today's webinar on the topic of Medicaid and CHIP 101 and American Indians and Alaska Natives. This is a Centers for Medicare and Medicaid Services ITU training webinar. My name is Julie Cahoon, and I am from Kaufman & Associates. I will be your moderator for today. The session objectives for today: by the end of today's webinar presentation, you should be able to describe Medicaid eligibility, benefits, and administration, including eligibility for those enrolled in both Medicare and Medicaid, define CHIP eligibility benefits and administration, and describe special provisions and protections for American Indians and Alaska Natives and Indian healthcare providers. There are upcoming webinars under this ITU webinar series. Please join us for these next webinars on Social Security and Disability Benefits on May 28th, Outreach and Education on June 11th, and Office of the Inspector General on June 25th. With those announcements made, I will now turn it over to Cindy Deluxey to introduce today's topic. Cindy?
Thank you, and good afternoon or morning, depending where you are, everyone. I'm delighted to be able to present to you today on Medicaid and CHIP 101 and how it relates to American Indians, Alaska Natives, and Indian health. So to give an overview of the first part of the slide, we're going to talk about what Medicaid is, the administration, eligibility, expansion of Medicaid that has come with the Affordable Care Act, coverage for mandatory Medicaid state benefits, state plan benefits, waivers, how Medicare and Medicaid are different, dual eligibles, and the Medicare Savings Program. So first of all, we're going to talk about what Medicaid is. It's a federal and state program that helps with medical costs for certain individuals and families with limited income and resources. Medicaid is not a cash support program. It pays medical providers directly for care. Medicaid is the largest source of funding for medical and health-related services for those with limited income and resources, and provides health coverage to an estimated 74 million people, including children, pregnant women, parents, seniors, and individuals with disabilities. The program became law in 1965 as a cooperative venture jointly funded by the federal and state governments, including the District of Columbia and the Territories, and it helps states provide medical assistance to eligible persons. There's also a link in the that we'll provide for you later in resources where you can get more information about Medicaid programs. So as I said, Medicaid is jointly administered by federal and state programs following federally established national guidelines. The states get federal matching funds known as the Federal Medical Assistance Percentage, or FMAP, and it's used to calculate the amount of federal money that goes to the state for costs of the Medicaid program. It varies from state to state based on per capita income. It varies from 50% up to about 75% in states, depending on the average per capita income for people living there. When services are provided to American Indians and Alaska Natives, the federal assistance share is 100% if those services are provided through Indian Health Service or Tribal Health Service. Within broad federal guidelines, each state develops its own programs. It develops and operates its own plan, establishes the eligibility standards within federal guidelines, determines the type, amount, duration, and scope of services, sets the payment rates for services, partners with the Centers for Medicare and Medicaid Service to administer the program, and administers it once the state plan has been approved by the federal government by the Centers for Medicare and Medicaid Services. States can change their eligibility, services, and reimbursement by submitting state plan amendments to the Centers for Medicare and Medicaid Services. Again, a single state agency, usually the Department of Health Services or the Department of Family Services, administer the Medicaid state plan. and they can delegate some administrative functions. Frequently, eligibility is delegated to social service agencies, public assistance agencies such as TANF, human services, and it can be delegated to tribes if the state chooses to do that. So here's a little knowledge check for yourself. Medicaid is A, a joint federal-state partnership, B, administered solely by contractors, C, funded solely by states, or D, a federal program. And the answer is A, a joint federal-state partnership. So in Medicaid eligibility, states are required to cover certain populations and groups like low-income families, qualified pregnant women and children, or individuals receiving supplemental security income or SSI. The states also have flexibility to cover other population groups like people who are receiving home and community-based services because they need supports to remain in their home, or children in foster care, or for example, women who have breast or cervical cancer. Those are all optional groups. Whether the groups are mandatory or optional, there are certain financial and non-financial requirements that have to be met for an individual to qualify for Medicaid. In all states, you can qualify for Medicaid based on income, household size, disability, family status, and other factors. The eligibility rules and amounts of maximum income can vary between states for certain groups. In states that have expanded Medicaid coverage to the adult group under the Affordable Care Act, you can qualify based on your income and non-financial eligibility factors like residence, citizenship, and so forth. Your household income has to be below 133% of the federal poverty level, but there's a 5% disregard, which brings that amount up to effectively 138% of poverty level in the expansion states. A few states have a different income limit based on some waivers or may cover some basic health program services as well. So as of 2020, 37 states, including DC, have expanded Medicaid. Nebraska has passed an expansion but will not be implementing it until the fall, so that's why they're in blue. The states in dark blue have all expanded Medicaid as of today's date. So if you live in a state that has not expanded Medicaid to adults, you may not qualify for Medicaid or the reduced costs on a private insurance plan in the marketplace. That's called a coverage gap. And you may be able to get a hardship exemption for carrying health coverage, although now with a law that was passed in 2018, they're no longer assessing penalties at this time for not having insurance. In any event, American Indians and Alaska Natives are exempt from this year's shared responsibility payment if that's ever instituted again. When the ACA or the Affordable Care Act passed, there was a decision made that people should be able to apply for the marketplace Medicaid and CHIP on one single application and not have to go fill out one at the state and one at the marketplace. So there's a single application where you can apply for and see what you qualify for in the marketplace or Medicaid and CHIP. If you qualify for assistance in the marketplace, you can get premium tax credits and sorry, I had something kind of block my screen. Sorry about that. You can get premium tax credits and cost sharing reductions. You can apply online, by phone or by mail or in person. You may be able to enroll immediately once eligibility determination is complete if the state has real-time or has real-time eligibility, or if you qualify for the marketplace. And that would depend on what program you qualify for as well. You can apply for Medicaid and CHIP at any time during the year. For the marketplace, there are open enrollment periods. However, tribal members can enroll at any time during the year. That was a special protection in the marketplace. And you can enroll at healthcare.gov or through the state agency where you reside. So when you go to the Streamlined application, in addition to asking for ethnicity in the beginning, there's another question that asks if anyone in your household is an American Indian or Alaska Native. If you answer yes to that question, it directs you to go to Appendix B. This is really important because Appendix B is used to make sure that Indians who are eligible for cost-sharing exemptions and for income and resource exclusions are counted properly. It asks an American Indian Alaska Natives individual relationship with healthcare providers, Indian healthcare providers, to see if you qualify for Medicaid, whether you would be exempt from cost sharing. It also asks about certain American Indian Alaska Native income and resources to make sure that they don't get counted for Medicaid if you're eligible for Medicaid. So sometimes people think that the questions are being asked to count the income for Medicaid, but they're really being asked in order to subtract that income from your household income to see if you qualify for Medicaid. And we'll talk about what kinds of income are exempt a little bit later in the slides. So when you go through the application process, most of it now relies on electronic data, and this is to reduce the need to have to bring a lot of documents to the place you're applying, to verify different things like your income. It used to be you had to bring pay stubs or letters from your employer or whatever. Now most of that is done electronically by interfacing with the IRS or unemployment records or other databases that tell the program what income you get. For many states, 12-month eligibility is the certification period, and it applies to adults, parents, and children. And in most states, retroactive eligibility is available for people who would have been eligible had they applied during one of the prior 3 months, and if they have unpaid medical bills in those months. Modified adjusted gross income, or MAGI methodology, is used for most Medicaid eligibility groups that apply to families and children. It is also used for CHIP eligibility, Children's Health Insurance eligibility. MAGI is tied to taxable income, so it is the taxable income minus 5% of income disregards. Household composition is also based on who is in the taxed household when you file taxes. Child support and other assistance are not counted because they're not taxable income. Indian monies that are not taxable income are not counted for the groups that are determined according to MAGI eligibility. And family size is adjusted for pregnancy depending on the number of kids expected. So if you're expecting one baby, it would increase the household size by 1. If you're expecting twins, it would increase it by 2. The groups that use MAGI eligibility are the expansion group, which are the adults 19 to 65. Parents and caretaker relatives, children, pregnant women. Certain groups do not have an income requirement, such as people who are already on SSI are automatically or Medicaid eligible in most states. Foster children are generally Medicaid eligible. Adoption assistance recipients, so if it's a subsidized adoption, those folks generally get Medicaid until they turn of age. People who are eligible because of age, blindness, or disability have a different set of standards for how eligibility is determined. People who need long-term care and people who are eligible for Medicare cost sharing have eligibility based upon similar cash assistance program, which is SSI. So in general, if income counts for SSI, it also counts for Medicaid, except for some exclusions I'm going to talk about a little bit later. And that's for those groups that are based on age, disability, or blindness. Verification is primarily a reliance on electronic data sources. There's a federal data services hub that pulls in Social Security benefits, IRS payments, taxes, Homeland Security information to determine citizenship. And this has resulted in a decreased reliance on documentation, so people don't have to do what I call chasing paper in the old days, where they had to drop off a lot of paper verifications of every eligibility factor for Medicaid. That could be a really intense process, and we've tried to move away as much as possible from that. So again, we're going to do a quick knowledge check here. Back to the Medicaid expansion slide and how many states have adopted the Medicaid expansion group to 138%. That should say 2020. And the answer is 37 states. So if you guessed that, you got it right. So there are certain benefits that have to be covered under Medicaid, and those are inpatient hospital services, outpatient hospital, what we call early and periodic screening, diagnostic, and treatment services for children under 21. That's very important because even if a state doesn't cover a service in their state plan, if a child is in need of a service and is medically necessary for that child to receive it, the state has to provide it even if they normally don't cover it for other individuals. So that applies to any child under the age of 21. Nursing facility services must be covered, home health services, physician services, rural health, FQHC services, lab and x-ray, family planning. You can read the rest of the list yourself, but all of these particular services have to be covered. The states then also have the option of using a Medicaid waiver to try an alternative delivery of care or demonstrate a theory that could save the state money or result in better health outcomes. Under those waivers, we have Section 1915B, which allows the state to enroll people into managed care. 1915C allows for home and community-based services for people who would otherwise have to live in a nursing facility because they need a certain level of care. This allows that care to be provided in the home. Section 1115 research and demonstration waivers, again, where the state can test a theory of a way that the state might save money or have better health outcomes from certain ways of delivering services. And some states actually pair the managed care waiver with community-based waivers and have a concurrent waiver where the folks in that group are subject to the terms of both waivers. Again, states have a lot of latitude in how they determine what they're going to pay to Medicaid providers. So states with CMS approval through the state plan determine how much they pay providers for individual services. The Indian Health Service, along with OMB, calculates and publishes a national or annual Medicaid reimbursement rate for Indian Health Service and tribal health providers each year based on certain facilities within the Indian Health Service. States generally pay that published rate, what we call the OMB all-inclusive rate or AIR rate, for services provided through tribal and Indian health service clinics. So now, probably the next 5 or 6 slides are the really key slides, key takeaways for today's conversation. And these are about special protections in the Medicaid statute for American Indians and Alaska Natives and Medicaid and CHIP. So the Recovery Act of 2009 set out 5 categories of special protections for American Indians and Alaska Natives and Medicaid and CHIP. And I'm going to go through what those are now because those are key protections and rights that Indian people have in the Medicaid and CHIP programs. So the first one is the cost-sharing exemption in Medicaid. Excuse me. American Indians or Alaska Natives who have ever used Indian health care providers, including IHS, tribal health, or urban Indian providers, are exempt from all premiums and enrollment fees, deductibles, co-payments, and co-insurance in Medicaid. So even if they go to a non-Indian health provider, they are eligible to have no cost sharing for that service. That includes deductibles and some of the high dollar co-payments and co-insurance. Indians who are eligible to use IHS, tribal or urban providers, but who have not ever done so, are exempt from premiums and enrollment fees. And then American Indian Alaska Native children are exempt from cost sharing in the CHIP program, whether or not they've ever used an Indian health care provider. The definition that we use in Medicaid for eligible American Indian Alaska Natives for these provisions and most of the other protections in Medicaid are the same as the definition of who is an eligible Indian for Indian Health Service. There are some payments for Medicaid that are not cost sharing, and I always like to mention those because it's a little bit confusing. So if you live in a state that covers the medically needy program, the amount that a person has to spend down to become eligible for Medicaid is not considered cost sharing. That's considered eligibility, and American Indian Alaska Natives are not exempt from paying spend down. The same is true for post-eligibility treatment of income for individuals in nursing homes or home and community-based waivers. There's what they call a patient liability or share of costs that patients must pay for that long-term care. And again, it's part of the eligibility requirement and not considered cost sharing under the statute. So American Indian Alaska Natives do have to pay that PETI, they call it, or post-eligibility treatment of income. The next protection I want to talk about is the income that is not counted for Medicaid or CHIP eligibility. These are monies that are not considered income for Medicaid or CHIP eligibility. So any distributions from trust or reservation property, income from property and rights related to hunting, fishing, and natural resources, income from the sale and use of cultural property or subsistence property, student financial assistance provided by the BIA or tribe, general assistance from the BIA or the tribe based on need, individual Indian money accounts, including those that are restricted or unrestricted, monies paid out from any exempt resources, which I'll go through in a little bit, distributions from the Alaska Native Claims Settlement Act, corporations, and settlement trusts. In addition, properties or resources owned by Indian Alaska Natives are exempt if they meet the following conditions. So if the property is located on a reservation or within the most recent boundaries of a reservation, and that includes real property improvements that may be individually deeded but are within those historical boundaries, and includes ownership interests in rents, leases, royalties, usage rights for the use of natural resources, fish, shellfish, harvesting animals, harvesting plants or timber, So, for example, if someone owns property within the reservation boundaries or previous boundary, and they lease that land out to someone to farm, for example, the income from that lease would not be counted, and the property itself is not counted against Medicaid eligibility. There are also exemptions for something called estate recovery. Estate recovery is something that the federal government requires states to do, and that is collect for monies that have been expended for Medicaid for long-term care services like nursing facility services or home health services for individuals who are over 55 and receiving Medicaid. States are required to go after the property that's left from the individual once they've passed away, so they're required to go after the estate. There are certain exemptions for American Indians and Alaska Natives in estate recovery that includes all the properties that we talked about on the previous slides located within the reservation or most recent boundaries, anything that is identified as Indian country or Indian lands, ownership interests in rents, leases, royalties, and usage rights, natural resources, etc. All the things that were exempt in those former slides are exempt from the estate recovery. And this is key here. It also includes items with religious, spiritual, traditional, or cultural significance, and also items that are left as a remainder in an estate in rents, leases, royalties, etc. So if someone has collected lease money off some Indian property and kept it in a bank account, and the heirs or whoever's inheriting the property can identify that as exempt property, then it cannot be taken or attached for estate recovery. So the state cannot place a lien or a levy on that property. The next protections I want to talk about are the managed care protections for American Indians, Alaska Natives. If an American Indian, Alaska Native is enrolled in managed care, whether it's voluntary or if the state requires it, they always have the right to go to an Indian health care provider, even if the Indian health care provider is not in the managed care network. So if an Indian goes to an Indian health care provider, rather than someone in the network, the state has to assure that the Indian health care provider receives their full state plan payment amount, which is usually that OMB rate that I talked about earlier. Also, the state and the managed care networks have to allow the Indian health care provider to make referrals for an American Indian Native to provider in the network when a referral is required, and they have to accept that as if it were made by a provider in the network or a primary care provider. That makes it so that the Indian person doesn't have to go to their primary care provider if it is not the Indian health care provider. Sometimes managed care plans automatically assign PCPs or primary care providers, and the Indian person may choose not to go to that provider. So I'm going to check your knowledge on the managed care. Does an Indian enrolled in managed care could go to an Indian health care provider without a referral, even if the primary care provider is not the Indian health care provider. Is that true or false? And the answer is that's true. So now I'm going to talk a little bit, if those of you that tuned in a couple of weeks ago for Medicare 101, I want to talk about how Medicare and Medicaid are different. Medicare is a national program that's the same in every state and territory across the country. Medicaid varies from state to state. We always say if you know one state's Medicaid program, you know one state's Medicaid program. None of them are the same. Medicare is administered by the federal government. Medicaid is administered by the state within federal rules, so it's a federal-state partnership. Medicare provides health insurance for people 65 or older, or disabled, or diagnosed with end-stage renal disease. Medicaid provides health coverage for people who meet financial and non-financial requirements. Medicare is the nation's primary payer of inpatient hospital services for the elderly and people with end-stage renal disease. Medicaid is the primary public payer of mental health and long-term care services and covers 40% of all births and prenatal and postpartum care in the United States. We also have dual eligibles, people who qualify for Medicare and Medicaid both. There are 8.3 million nationally who qualify for this. Medicaid may provide full benefits or partial assistance with Medicare costs. We're going to talk about Medicare savings programs, which are partial Medicaid benefits that help pay Medicaid premiums and sometimes cost sharing. You can qualify for full Medicaid only, full Medicaid within a Medicare savings program, or just Medicare savings programs. For those with full Medicaid, Medicare pays first, then Medicaid pays second, and of course, Indian Health Service or Purchase Repair Care is always the payer of last resort. So there are groups of Medicare Savings Program recipients. There is the qualified Medicare beneficiaries at 100% of poverty, specified low-income beneficiaries at 120%, qualified individuals, qualified disabled working individuals at higher income rates. Any of those groups automatically qualifies the recipient for extra help for Part D Medicare. In addition, anyone who's on one of these programs cannot be sent balance billing. So, for example, if the provider normally charges a higher private pay rate than the Medicare plus the cost sharing they get from QMB, for example, they cannot bill the Medicare and QMB recipient the balance of that bill. That's also true for regular Medicaid. If a provider accepts the Medicaid payment, they can't balance bill the patient. They can only charge them cost sharing, which in the case of American Indians and Alaska Natives that, use or have used IHS, that amount would be zero. So they can't balance bill the patient. What do the Medicare savings programs pay? The QMB program pays Part A and Part B premium, other cost sharing like deductibles, co-insurance, and co-payments. SLMB pays Part B premiums only, as does QI, and QDWI pays the Part A premium only. So here's another knowledge check. If you qualify for a Medicare savings program, you don't have to pay any deductibles, co-insurance, or deductibles, or co-payments, co-insurance, or deductibles. And the answer is that's only true for QMB. The others only pay the premiums, basically. Now I'm going to go quickly through the Children's Health Insurance Program, and then we'll open things up for some questions. So we're going to talk about what the CHIP program is, state options, eligibility, documents, and authorization and funding. So the Children's Health Insurance Program, or CHIP, is health coverage for uninsured children and families who earn too much for Medicaid but too little for private insurance. Jointly funded by the federal and state governments. It's administered by states, and over almost 9 million children are enrolled. All 50 states, including DC and the territories, have adopted CHIP programs. States can design their CHIP program one of three ways. They can do a Medicaid expansion. where they just expand the income limits for Medicaid, and 8 states, including the District of Columbia and 5 territories, have opted to do Medicaid expansion. They can do a separate CHIP program. This says there are 2 states. I don't think that's right. Oh, maybe so. 2 states that do a totally separate CHIP program. And then there are 40 states that do a combination. So expand some of the Medicaid groups up to a higher income level, and then also do a separate program at the higher income levels. So Children's Health Insurance Program, the eligibility is for targeted low-income children under the age of 19. They must be uninsured and not eligible for Medicaid. Most of the programs go to 200%, or 50 percentage points higher than the Medicaid level in 1997. They cannot have access to public employee insurance unless it's not affordable. So state employees generally cannot enroll their kids in CHIP. And they can't be an inmate of a public institution. And then the state defines the standards. The average coverage level is 255% of the FPL. North Dakota is below that at 133%, I believe. Indiana is above 200%. New Jersey and New York are the highest at 350 and 400%, respectively. So the Healthy Kids Act and Access Act extended CHIP funding through 2027 and provides $148 million for outreach and enrollment efforts. And that includes grants that were given to Indian health providers. So the knowledge check. States have some flexibility in designing CHIP. True or false? It's true. So the next several slides, which you'll be able to obtain later when they're posted, give you resource links. Excuse me. Now I think we'll stop and go to questions. I'm going to hand it back to Julie.
Great. Thank you, Cindy. We will now move into the Q&A portion of the webinar. Please enter your question into the Q&A pod located at the bottom right side of your screen. And so we do have a number of questions that have come through, which is great. All right, our first question is, how is the MAGI calculated? What formula is used?
So the MAGI is based on taxable income. So it's the same formula as the monies you would report when you file income tax. But then certain things are deducted, in particular for American, that protected property is deducted, the monies from that property, so that it brings it down to a lower income level.
Great, thank you. The next question is, why do so many of our elders have Medicaid spend downs that are more than the income they regularly receive in a month?
So that should not happen, ever. I mean, the spend down is to spend down the monies that you receive to the income level, which is usually fairly low in those medically needy programs. If that's happening, I would recommend that you go to the website that's displayed on the screen right now. It gives you information about who your Native American contact is. You should contact them and have them look into exactly what's going on that would result in them having a higher spend down than their income.
Our next question is, how is eligibility determined for American Indians and Alaska Natives with disabilities?
So when someone qualifies for Medicaid based on their disability, there's a test of whether they meet the criteria of being permanently disabled, and that is based on SSI criteria. And then the income is counted in the same way that SSI counts it. But again, the special protected properties and income are subtracted out where SSI might count and Medicaid would not.
Great. And Cindy, would you mind clarifying what OMB stands for?
I'm sorry, the Office of Management and Budget, and they work with IHS to calculate that annual all-inclusive rate.
Great, thank you. So our next question is, do cost-sharing exemptions also apply to the medical assistance premium plan?
I'm not sure I'm familiar with what that is. Kitty, do you know?
No, I haven't heard that terminology.
That may be a local acronym. Maybe ask the question and explain what program we're talking about.
Okay, so we'll move on to the next question. And the next question is, MAGI does not use resources to determine eligibility. Are there any CHIP applications that SSI rules apply to?
No. The CHIP are all for children, and they're not based on disability. So SSI rules do not apply, and they should be following the MAGI calculations, which do not use resources.
Okay. The next question is, some state Medicaid applications require a parent to disclose the name of a CHIP-eligible child's other parent to track child support as income. If this is not disclosed, the parent may not be eligible for Medicaid. Does this apply to American Indians and Alaska Natives?
So generally in Medicaid and perhaps in CHIP, I don't recall, but generally there's a requirement that an individual applying for the program has to go after other sources that could pay for the care. So not really after the income, it's about medical support. And children cannot be penalized if the parents don't cooperate, but the parent could be penalized and removed from Medicaid. I know there have been efforts to not apply that to American Indian and Alaska Natives because tribes operate their own child support agencies, but I'm not sure if it's actually prohibited. Kitty, do you recall?
No, sorry, I can't. I don't remember that. So, sorry.
In any event, the child's eligibility should never be affected, although, as you point out, it may affect the parent's eligibility if they don't qualify. And every state has to provide a process for claiming good cause for not going after child support, so the parent should have an opportunity to explain why they don't want to pursue child support, such as if the person was abusive or there's some reason that it would be detrimental to the child or other reasons like that would qualify as good cause.
Okay, thank you, Cindy. Okay, so we will now pause to take a few questions from the phone through our operator. Operator, can you please give instructions for asking a question over the phone?
If you would like to ask a question from the phone lines, please press star, then 1 on your telephone keypad now. Once again, in order to ask a question from the phone lines, please press star, then the number 1 on your telephone keypad now. Please stand by while we compile the Q&A roster. There are no questions at this time.
Okay, so we will go ahead and continue taking questions from the Q&A pod. So our next question is, do the MSP requirements apply to all categories or just QI?
Well, I'm not exactly sure what requirements we're talking about here, but the Medicare savings programs apply to QMB, SLMB, QI, and QDWI. So all of those Medicare cost sharing plans follow the same resources, income counting processes, if that's what the question is.
Okay, thank you. So our next question is, some of our tribal children are being enrolled in a dental program that does not cover any local providers. How can this be prevented in the future?
That's a situation where I would reach out to your Native American contact at the link that's on the screen. Excuse me. The state should assure that they're being enrolled in local programs. The second thing is if they're being enrolled into a dental managed care program, they can always go to the Indian Health Service or tribal health provider or urban program for that dental care if it's available there. And the managed care plan would have to pay those programs for the care that's provided.
Okay. What is the specific definition of American Indian and Alaska Native for the purposes of Medicaid? Does someone need to be a registered tribal member?
So it's a rather long definition that is equivalent to who is eligible for IHS and tribal and urban services. But they do not have to be a tribal member necessarily. They can be a descendant or someone with a blood quantum that may not be enrolled as a tribe. And Kitty, I invite you to add to that if you want.
Well, yeah, and it also includes urban Indians that are residing in an urban Indian center. So the definition is very broad, and basically it's the same definition of individuals that would be eligible for IHS. So it includes California Indians and urban Indians, Alaska Natives, and tribal members and descendants.
Okay, thank you. Our next question is, which services are retroactive, and how do the patients request if they have received a bill?
So generally when you apply for Medicaid, the application asks if you have any unpaid bills in the 3 months prior to application. If you answer yes, the state may request information about your income those months to determine if you would have been eligible had you applied back in those months. If they determine that you would have been, then you get Medicaid, and those bills that you're getting, the provider can go back and bill Medicaid and get that payment for those bills so that you wouldn't have to pay them.
Okay. Our next question is, are the IIM exempt?
Individual Indian money accounts or IIM accounts are exempt. from counting for resources, and distributions from them are not counted as income.
Okay. The next question is, does an individual need to already have Medicaid to qualify for Part B Medicare savings program?
So an individual can apply to get QMB or SLMB or QI1, those programs to pay the Part B Medicare premiums without being on other Medicaid programs. So they have their own eligibility determination. And if you meet it, then you get enrolled in the Medicare savings program and the state pays for those Part B premiums.
Is a patient with Medicaid coverage also automatically covered for dental insurance?
No, dental is a optional benefit. Children have to be covered because of the EPS-DPT program I mentioned before, the Early Periodic Screening, Diagnosis, and Treatment program. But states do not have to cover dental for adults, and some states do not. So states can cover it as an option, but it's not required.
Okay. The next question is there a navigator's training available for NSA AI who need help with the application process?
I'm not sure I know what NSA AI is, but there are navigator programs. Generally, navigators are organizations that get grants to assist with enrolling in the marketplace. And there are training programs for navigators and assisters every year on the marketplace, if that's what the question is about.
Okay. What is the difference between MA and MAEPD?
I'm not, MA is generally an acronym that means medical assistance, but I don't know what MAEPD stands for, so I'm sorry.
Okay, the next question is child support taken into account for American Indians and Alaska Natives with a permanent disability?
Well, I'm not sure if the question is whether it's deducted for individuals with a disability that pay it out, or exactly what the question is. So I'm sorry, I don't have enough information, I guess, to answer that.
And this is Kitty. Just real quick, we have DTA has a mailbox, and so if we're not able to answer your question and you want to follow up, you could send this question to tribalaffairs@cms.hhs.gov. So again, that's tribal affairs, all one word, tribalaffairs@cms.hhs.gov, and then include your contact information and we can follow up with you. Go ahead, Julie. Thank you.
Okay, great. All right. Our next question is, how long does it take to process a Medicaid application? Does Medicaid for prisoners take longer to process?
So states have 45 days to process a Medicaid application for most programs, definitely for the MAGI-related programs, so families children, eligibility, pregnant women. The states can have up to 90 days to process an application for Medicaid based on a disability because it sometimes takes longer to get a disability determination from the medical providers. So those are the general timelines that the state has to process. The second question about Medicaid for prisoners, Medicaid is not available for people who are inmates in public institutions such as prisoners. So generally, there is no Medicaid available for who are incarcerated.
Okay, thank you. So our next question is actually a follow-up to a previous question where there was some confusion about MAPP. So the revised question is, in Wisconsin, there is a program called the Medicaid Purchase Plan, where the state charges premiums if the disabled person's income is over the 250% FPL. Is there a way to prevent this?
Okay, so this is it's either under the Balanced Budget Act back in '97, or it's a Ticket to Work working disabled program. In both those cases, the states are allowed to charge premiums because these are folks who would otherwise lose Medicaid because of earnings. They're allowed to earn the money and keep their Medicaid, but there is a premium that is charged for folks whose income is above 250% of poverty level. So that's one of the conditions of getting Medicaid through these groups. So there's not really a way to prevent paying that premium for those programs.
Great. Thank you, Cindy. So our next question is, how long does it take to process a Medicaid application? Does Medicaid, lost my place.
That's all right.
The next question is, do American Indians and Alaska Natives have to apply for Medicare at age 65?
Well, there are, everybody becomes eligible for Medicare at age 65 if they have the working history to qualify. If they don't enroll within the initial enrollment period, generally then when they enroll later, they are assessed a penalty for not enrolling when they turn 65. There are a few exceptions, like if they're still working and getting group insurance and things like that. But generally, if they don't apply, there will be a penalty assessed later, and American Indians are not exempt from that Part B penalty.
Okay, thank you. And just a note to folks, we have reached the top of the hour, but we have just a few more remaining questions in the Q&A queue. So we will just go ahead and move just a little bit beyond our time and respond to all of the questions. The next one is, does DWI only qualify for Medicare Part A and not eligible for MSP?
So DWI is a MSP program, but it's a program that pays a Part A premium for people who don't have enough quarters of work to pay for Part A. Generally, if you don't have basically 10 years worth of working history, you have to pay for Part A. It's free for anyone with enough work history, and it's a very high premium. So the DWI qualifies people for that Part A premium assistance through the state. So it's only for Part A. But there are the other programs for Part B, which are QMB, SLMB, QI.
Okay, great. Our next question, can the local income manager receive the SSN from Social Security if the parent or guardian does not comply? Would this stop the child from being covered by medical assistance?
So generally, everyone in Medicaid provide proof of citizenship and Social Security number. There are the religious exemptions, but for the most part, people have to put their information. Oftentimes, hospitals will assist that, or can apply for.
Pardon me. Sorry. Would you mind repeating your response? It was a bit muffled and it was unclear.
I'm sorry.
If you could just respond.
Okay. Can you hear me now? Can you hear me?
Yeah.
Okay. Okay. So generally, a Social Security number and citizenship information is required for Medicaid. Indian documents work for citizenship, but everyone is required to apply for a Social Security number unless they have a religious exemption or something like that, except for some special emergency groups. So a lot of times eligibility offices will help parents apply for the Social Security number for children. Hospitals do that when they're born. But I don't think an individual can apply for that number without the permission and the system and the guardian.
Okay. Thank you, Cindy. So we just have 2 questions remaining, and then we will close the session. The next question is, are tribal gaming income or per capita payments exempt from counting this as income to enroll with medical?
So monies from casino earnings that are paid out by the tribe to individuals are countable income. Other per diem payments that are based on excluded resources or income are not counted. So it depends on what monies the tribe pays out in those per capita payments.
Okay. Thank you. So our last question is, do you have any information on patients who are not legally documented? Are they able to apply for Medicaid?
So individuals who are not, who cannot provide proof of citizenship and Social Security number can be eligible for only emergency Medicaid if they otherwise would qualify if they were a citizen. So if a family would qualify for Medicaid if they were citizens, they can get emergency Medicaid for life and limb-threatening situations, including labor and delivery. But they cannot get general Medicaid.
Great. Thank you, Cindy. And that will conclude our question and answer session. And so I'd like to remind everyone again that there are upcoming ICU training webinars in this series. The next webinar will take place on May 28th, and this will be about Social Security and disability benefits, and we encourage you to register for the remaining webinars. Thank you for joining today's webinar. Our session is now concluded. Have a great rest of your day.